the invaluable opportunity to accompany him on rounds. Those days were a turning point. Under his guidance, I learned to look at infections not just as diagnosis, but as evolving stories shaped by patients, organisms, and drugs. He taught us how antibiotics are not merely prescriptions, but precise tools whose PKPD behavior varies from patient to patient. His clarity of thought, depth of knowledge, and ability to simplify the most complex concepts have been a constant source of inspiration. Even after completing my own super specialty in critical care medicine, it is because of him that my interest in infectious diseases not only remained alive, but grew stronger. In many ways, he has been my indirect mentor, shaping my approach, my curiosity, and my respect for this ever-dynamic field. It is truly an honor to welcome such a visionary clinician, a respected teacher, an inspiring leader. So everyone present here, please join me in warmly welcoming the legend in infectious disease, Dr. Atul Patel, sir.
It is very simple because Dr. Atul Patel doesn't need any introduction. He was the first person to start exclusive infectious disease clinic in Gujarat. He was the first infectious disease specialist in Gujarat, and he has trained many fellows in infectious diseases from his clinic in Ahmedabad. He has also got affiliations with one university in Tampa, Florida. In Ahmedabad, he has affiliation with Vedanta Institute of Medical Sciences, Navrangpura. Over to Dr. Atul Patel.
Yeah, good morning, everyone, and thank you, Chairman, for a kind word of introduction. I'm also thankful to the Critical Care Society and the organizers for inviting me over here. The topic they have assigned to me is the invasive fungal infections in ICU. So we know that like when I was a student, like in 1988, when I was doing my MD, we come across only two fungal infections. One was oral candidiasis, and second was mucormycosis in uncontrolled diabetic patients. And after that, like we are seeing so many the invasive fungal infections, and the important reasons for this rising incidence of fungal infection in our day-to-day practice from early 80s and 90s to 2025 is the use of broad-spectrum antibiotics. So we just bombard our patients with broad-spectrum antibiotic to treat their gram-positive and gram-negative infections. The another important reason is like use of immunosuppressives, like previous talk highlights the use of corticosteroids. But there are so many other indications of immunosuppressives in ICU, including the patient who has received organ transplant. The invasive medical intervention just to prolong the life of the critically ill patients like will also very important risk factors for the rising incidence in fungal infections. Prolonged ICU stay, blood transfusions, highly ignored the topic in management of critically ill patients, but remember that blood transfusion is a liquid organ transplantation. So it induces the immunosuppression. So if you are transfusing 1 unit, 2 unit, 3 units to your patients, it induces the immunosuppressions to your patients. But the important new reasons where the fungal infections in ICU is rising would be the severe viral respiratory infections. And we know about the COVID virus, but the influenza is more commoner virus which induces the invasive fungal infections in ICU admitted patients. So influenza-associated pulmonary aspergillosis is a very important risk factors in ICU admitted patients. The COPD and the CLD are the newer increased the risk group populations in the ICU admitted patients. The another reasons why we are having more and more fungal infection is also related to the improved understanding of the epidemiology and also improved diagnostic capabilities of microbiological laboratory to pick up more and more fungal infections. So these are the reasons why we are getting more and more fungal infections in our ICU setting. When we look at the prevalence of fungal infection in ICU, this is a very important study looking at the prevalence of fungal infections across the globe. And the most important, the summary findings of this study is that if you look at the high-income countries, the incidence of fungal infection is just 3%. The upper middle income countries, it is jumps to 6%, but the poor countries, it is 21%. So if you look at the continents, the South America 15%, Africa 16%, Asia 10%, and America and the Europe is 3 and 4%. So what this means, this directly related to the epidemiology of the fungal infection as well as the hospital infection control practice. This is what we have to understand, like, though we know that the fungal infection incidence is rising globally as well as in our settings, but how do we make a diagnosis? The diagnosis is always challenging. It is not that easy. That some test comes positive, that means that patient is having fungal infection, it's not so. So for making a diagnosis, the basic microbiological tests like direct microscopy, culture, and the histopathology, these are the basic microbiological tests. These are still very important and the gold standard to make a diagnosis of invasive fungal infection. So you cannot underscore the value of microscopic examination and the cultures. But the issue is that when you rely solely on the cultures, the sensitivity of the blood culture is generally poor, like it is ranging from 50 to 70%. That means you are going to miss half of the patient who has the invasive fungal infections. And the second important thing is that the yield is also low, so you require a very large amount of the fluid, either it is a blood or the respiratory secretions to get a culture positivity. The non-culture based diagnostic tests, these are very exciting, and that has improved the diagnosis of invasive fungal infections in our day-to-day clinical practice. And more than 80% of the serious invasive fungal infection has been diagnosed by these non-culture based diagnostic tests. So we are going to touch upon what are these non-culture based diagnostic tests. But remember that interpretation of all these non-culture diagnostic tests are very tricky. It is not simple that test is positive, it doesn't mean that the patient is having fungal infection. So there are two common fungal infection in ICU. One is the yeast infection, and the second is the mycelial structure. In the yeast, the Candida is the commonest one, followed by the Cryptococcus, and in the mycelia, Aspergillus and the Mucorales are the two common fungal infections. So let us talk about the Candida in the ICU. So this is a burden of invasive candidiasis. So in a culture positive, you can see that every year, like we are looking at 600,000 of patient who has invasive candidiasis because of candidemia or the bloodstream invasions, with a mortality of nearly 40%. And in India, if you look at the published literature available, the mortality of candidemia in Indian setting is more than 50%. That means that half of the patient are going to die if you have a blood culture positive for Candida. But when you talked about the invasive candidiasis without positive blood culture, that means the deep-seated Candida like intra-abdominal candidiasis, pancreas, bone and joint involvement with the Candida meningitis. So these numbers grows up to 900,000. So see the significant burden of invasive Candida infection globally. And this invasive Candida typically occurs in a patient who has a pre-existing risk factors. You all know about what are those risk factors, so I'm not going to touch upon. And it can also occur in ICU setting as well as in the patient who has hematological malignancies. But the important issues that has been found in last decades is there is an increase in the difficult to treat invasive Candida patients. So this is what is new in invasive candidiasis. And the underlying host factor is very important in these difficult to treat invasive Candida patients because of IL-17 inhibitors and occurrence of invasive Candida infection. The another thing is emergence of antifungal resistance to Candida tropicalis, Candida parasilosis, and emergence of Candida auris. So these are the very important issues, and nowadays in European countries as well as in United States, the Candida glabrata, which has become resistant to echinocandins also. So these are the most important emerging threats in invasive candidiasis. So how do we make a diagnosis of invasive candidiasis? I told you that the blood culture is a gold standard. So make every effort to collect a blood cultures for making a diagnosis of invasive candidiasis. The reason is that if you look at the clinical presentations of invasive candidiasis, patients can have very non-specific features, starting from the very minimal fever to a full-blown sepsis, just like patient who has the bacterial infection. So the spectrum is huge. So you have to keep a very high index of suspicion to pick up more and more cases of invasive candidiasis. And there are very minimal signs which are associated with the invasive candida infection. You may get some skin rashes, which is generally maculopapular erythematous rashes over the skin. Patients can have eye involvement, but it is not that common. And less frequently, patients can have muscle abscesses because of candidiasis. So there are very minimal signs, and the clinical presentation is entirely a non-specific. The blood cultures are very important, but the non-culture-based tests like beta-D-glucan, menon, anti-menon, candida albicans, germ tubes, antibody, or the CACTA, T2 candida, and PCR. These are the n number of tests which are available to us for making a diagnosis of invasive candida infection. So let us understand like how we can interpret this test, right? This is very important to understand. So this beta-D-glucan, which is commonly used, and it is now available everywhere. So remember that this beta-D-glucan is useful only in a high-risk group of the patients. So if your patient do not have a risk factor for invasive candidiasis, and if you are determining a beta-D-glucan, and if it comes positive, it will not tell you anything, right? So only in a high-risk group where the prevalence of invasive fungal infection is more than 15%. Remember, so in ICU, typically the patients who are receiving parenteral nutrition or undergone the GI surgery, patient is having central venous line, multiple antibiotics. So these are the very important risk factors where you expect prevalence of fungal infection more than 10%. And in these settings, the sensitivity of beta-D-glucan is 81% and the specificity is just 60%. So positive beta-D-glucan, even in a high-risk patient, will not tell you that this patient is having invasive candida infection. So this is what you have to remember, and don't put your patients on antifungal therapy just based on beta-D-glucan positive. So when you do not have a microbiological evidence of invasive candidiasis, the two consecutive beta-D-glucans separated by 3 to 5 days is one of the very good marker which can tell you that, look, this could be a invasive candida infection. So two consecutive beta-D-glucan in absence of microbiological evidence is one of the marker where you can have in a high-risk patient that this patient is having invasive candida infection. So this is what you have to understand to make a diagnosis and the use of beta-D-glucan. Beta-D-glucan test performance can also vary by the species. So if you are having candida albicans, the beta-D-glucan is generally very high, as compared to the patient who has candida parasilosis and the candida auris. So look at this, like in candida albicans, the beta-D-glucan levels are generally high as compared to parasilosis and auris. Auris is the lowest the beta-D-glucan levels. So this is how like you may get a falsely negative or very low beta-D-glucan even when the patient is having invasive candida infection because of parasilosis or candida auris. So this is what you have to understand in your clinical practice. So how do we, make the use of interpretation of all these non-culture-based technique in making a diagnosis? So look at this. This is an excellent study from the Nguyen and the Clancy. If your prevalence is just 0.4%, so random patient where you have asked for the beta-D-glucan or the menon, anti-menon, or the T2 candida and PCR, where you do not have any cause and you just, throw the test just to make a diagnosis of invasive candida infection. So where patient does not have any risk factors, look at the positive predictive value, it is just 1%. But the negative predictive value is almost 9900%. So this is a value of all these non-culture-based tests. So in this patient, if all this beta-D-glucan or the T2 candida and PCR comes negative, that means that your patient does not have invasive fungal infection. So this is what information that you can get. So it has got a very high negative predictive value. But if your patient's prevalence of invasive fungal infection increases up to 10%, then sensitivity and the specificity or the positive predictive value and negative predictive value is increases, right? So remember that all these non-culture based tests, they have a very high negative predictive value rather than positive predictive value to make a diagnosis of invasive candida infection. Now coming to the another fungus, that is Aspergillus, which is also very common in our ICU practice. So the most important risk factors for invasive aspergillosis, we know that that is hematological malignancy patient, those who are neutropenic, acute myeloid leukemia, induction therapy, HSCT, GVHD, those GVHD which requires corticosteroid therapy. So these are the classical risk factors. The solid organ transplant and the immunosuppressive recipients, they do also categorize into the classical risk factors. But the things that you as a critical care specialist should know is the other important newer risk factors which has arise for invasive aspergillosis, and one of them is tyrosine kinase inhibitors. So those patients who are on ibrutinib or the other drugs similar to the tyrosine kinase inhibitors, this is one of the very important risk factors for development of invasive aspergillus infections. The patient who are receiving the CAR T cell therapy, especially when they develop cytokine storms. So CAR T therapy is not a risk factor, but when they develop cytokine storms, these patients are likely to get invasive aspergillus infections. And the non-traditional risk factors are the ICU patient with COPD, with ARDS receiving corticosteroids. So previous talk highlighted the use of corticosteroids in these two indications like COPD and ARDS. But remember that like when you are using these corticosteroids to this group, it also increases the risk of development of invasive aspergillus infection in this group and the chronic liver disease. CLD is always under-recognized as a risk factor for invasive fungal infection, but now more and more publications who has described cryptococcal infections as well as the aspergillus infections in CLD patients. Viral respiratory infections that we have already touched upon, and the RSV is new kids on the block, which also precipitate invasive aspergillus infections apart from influenza and the COVID-19. So this is how we can differentiate IAPA from kappa, that is from COVID-associated pulmonary aspergillosis from influenza. The most important difference that you should remember is for influenza, like you will get early invasive pulmonary aspergillosis within 3 to 4 days of hospitalization of influenza patients into the ICU, that you are likely to get invasive aspergillosis as compared to the COVID patients where it is more delayed onset, and generally the patient is on therapy in ICU on ventilator for several weeks before patient develops invasive aspergillosis. So IAPA is an early infection and this is a delayed onset of aspergillus infection. And this is the mortality, though mortality is higher in both the conditions, but influenza has higher chances of survival. So what are the challenges? Like how we can make a diagnosis of aspergillus infections in ICU? So just like the candida infection, this is also a very challenging one. The culture is frequently sterile. From respiratory samples, like if you are getting a culture positive for aspergillus, like many times it could be a normal colonized flora, right? So aspergillus is a normal component of our respiratory tree, right? So it cannot tell you that this patient is having invasive aspergillosis. The direct microscopy is generally rarely requested by the most of the clinicians, but it is extremely important from the biopsy as well as from the needle aspiration sample, because if you are aspirating CT-guided pulmonary aspiration or aspirating the abdominal cavities, and if you are demonstrating the positive direct microscopy, it is a very good evidence that your patient is having invasive aspergillus infections. Histopathology, sometimes it's very difficult to get because of the deep-seated lesion, patient is having hematological conditions, thrombocytopenia, and so on. So, I mean, this is again, this can confirm the diagnosis, but this is sometimes very difficult. The fungal biomarkers, we do have biomarkers for making a diagnosis of aspergillus infection, but interpretation of these fungal biomarkers is very tricky, just like beta-glucan. So your galactomannan positive does not say that this is invasive aspergillus infection. The molecular techniques aspergillus PCR is now readily available, and it is well standardized in several countries. So we are going to get aspergillus PCR soon, but the cost and the turnaround time is a big issue. The radiology, the CT scan is very important, preferred over the X-ray chase for making suspecting a diagnosis of aspergillus infection. So you can get variety of pictures on CT scan, like from the nodules, dense circumscribed nodules, the conglomerated nodules, some cavitations, air crescent sign. So variety of radiological features that you can see on the CT scan. And for patient who has chronic pulmonary aspergillosis, again, you can see variety of the CT scan pictures. So from radiology, probably you will be able to suspect, looking at the dense nodules, conglomerated nodules, some halo, some cavitation, that these patients could have underlying aspergillus infection. And from these suspicions, like, you have to make a diagnosis. You have to confirm a diagnosis. So how do we make a diagnosis? Let me take you to a small case. So this is a post-renal transplant patient with stable immunosuppression, develops diabetes after transplant, and she was admitted with left mid-zone multiple nodular conglomerated lesion. This is a CT scan. And patient has persistent fever and the respiratory symptoms despite azithromycin and ceftriaxone. So this is a clear-cut indication that this patient has not responded from community-acquired respiratory infection. And this were the WBC count and creatinine. And the serum galactomannan was 0.4, and the beta-D-glucan was done, which was positive, 104 picogram. So 84 is the cutoff. So ID reference was done. Now, how we are going to interpret this? Though patient is having a renal transplant, stable immunosuppression, no response to antibiotics therapy, and serum galactomannan is 0.4 and BDG is 104. So this is how, we have to understand, how we are going to interpret this galactomannan. So let us understand, what is the value of galactomannan in non-neutropenic settings. So serum galactomannan, meta-analysis shows that the overall sensitivity of galactomannan is 71% and specificity is almost 90%. But when you remove the hematological patients, right, the sensitivity and specificity drops to 22% and 84%. So when you are talking about non-hematological, non-neutropenic patient, the galactomannan has much lower value in making a diagnosis of invasive aspergillosis. Like my patient, the galactomannan is just 0.4, which was negative. There is another study which showed that in non-neutropenic setting, the serum galactomannan has 37 and the specificity is 87. So again, similar results of the meta-analysis. So how do we interpret? Let us understand. So when you are using a cutoff of serum galactomannan to 0.51 and 1.5, the sensitivity, this is overall study. Sensitivity from 78 drops to 0.48 when you increase the cutoff. But the specificity, it increases, it will remain around 85 to 95, and the positive likelihood ratio is much better, and negative likelihood ratio is much better. But when you subgroup these patients into hematological malignancy, HSCT, and SOT, the SOT patient has 40% and 85% specificity, and the positive likelihood ratio is 2.73. HSC patient, because they have many confounders in patient who has received bone marrow transplantation, so the value of galactomannan is much less as compared to SOT patients. So that you have to remember because of the false positive results. But when you look at the BAL galactomannan in these patients, in these groups, again using a different cutoff from the 0.5 to 2, the sensitivity drops when you increases the cutoff, which is what is expected, but the specificity increases from 90% to 96%, right? And positive likelihood ratio and negative likelihood ratio remains decent for this group. But when you look at hematological patient and the non-hematological patients for BAL galactomannan, it is same. There is no difference. That means that if your patient is non-neutropenic and if you want to make a diagnosis of invasive aspergillosis, then probably the BAL galactomannan is an investigation of the choice, right? But the only confounder here is that if patient is on antifungal prophylaxis, then the value of galactomannan goes down as compared to a patient who is not on antifungal therapy. The reason is that galactomannan comes from the replicating aspergillus. So once you put them on antifungal therapy, the replicating birds will be cleared by the antifungal agents, and the galactomannan value drops drastically. So BAL galactomannan is desirable in our ICU patients or the non-neutropenic patients. So this patient was having a sputum, so it showed 25 to 30 cells, KOH, no fungal elements, fungal and bacterial culture sterile at 48 hours, but the sputum galactomannan was 2.63, right? So now the question comes like, should we go for a BAL or the sputum galactomannan is good enough? So if you look at the overall sensitivity and specificity of the galactomannan performed from the upper respiratory secretions as compared to the lower, that is from the sputum and the tracheal aspirate with the BAL, the performance is the same, right? So look at this. This is a proximal airway galactomannan where when you are using a cutoff of 0.7 as compared to 0.45 from the BAL, look at the ROC curve, it is same. Right, so you can very well perform the galactomannan from the sputum examination. So this my patient who has galactomannan 2.63. Does this say that this patient is having pulmonary aspergillosis? So again, you have to follow the diagnostic criteria, and these are the URTC MSC criteria. So you have to look at the host factor, clinical picture, and the microbiological features, right? So this is how like you have to interpret. So if you look at my patient, the host factor is appropriate, organ transplant, patient has clinical and the radiological parameters, and mycological features, I have galactomannan positive. So final diagnosis would be probable invasive pulmonary aspergillosis as per the EORTC MSC criteria. So this is how you have to make a diagnosis of invasive fungal infection or the invasive aspergillus infection in your clinical practice, right? So there are other important criteria. So my patient was organ transplant, that's why I have used EORTC MSG. But in ICU patients, like all patients are not immunocompromised. So you have to use this SICU criteria, where entry criteria is positive aspergillus culture from the respiratory secretions, right? So those patients who has sputum, BAL, or the tracheal aspirate comes positive, then you have to look at the clinical criteria, at least one of the following criteria, and abnormal pulmonary imaging, which includes any infiltrates. No need to have nodules. Any pulmonary infiltrates qualifies for the aspergillus criteria. And host factors like these are not strictly applied, but the presence of host factors like patients on immunosuppressions, corticosteroids, patient with COPD and the cirrhosis. So these are the two very important risk factors that has been entered into the SICU criteria. And here, like, because it is the probable, so putative IPA diagnosis can be made by this. And nowadays, like, the galactomannan has been included into this SICU criteria, right? Galactomannan BAL more than 1 or the serum more than 0.5 has been included in this criteria. So this is how, like, you have to use the diagnostic criteria to make a diagnosis. So combining diagnostic assay will improve the sensitivity. So I'm not going to